Welcome, everybody. Welcome to the Aging Communities and Pandemic Lessons. Are we prepared for the next infectious disease threat? I'm your host for tonight, along with the MIRA at McMaster. My name is Alexandra Papiano. I'm a professor of medicine at McMaster, and I'm a geriatrician at Hamilton Health Sciences, and a member of MIRA, which is our big research institute at McMaster. So we'd like to begin by acknowledging that the lands on which we gather is the traditional territory of the Haudenosaunee and the Anishinaabe nations. The territory was the subject of the Dish with One Spoon Wampum Belt Convent, an agreement between the Iroquois Confederacy and the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. For those of you who haven't seen it, we have a wonderful display of Indigenous art at our own Hamilton Art Gallery that many of the pieces came from Shidok, where many children and originally used the soapstones to develop carvings while they had tuberculosis. So thank you for joining us today through in person, and I know some people are live streaming. The McMaster Institute on Research in Aging, which is MIRA, the short form, in partnership with Canada's Global Nexus for Pandemics and Biological Threats, is excited to share this evening with you. Older adults and people who care for them were the most impacted by COVID. Many of our speakers are going to touch on this today. How did we let this happen? And how can we prevent this from happening again? Have we learned these lessons, or are we just continuing to unmask and going forth without any changes? What we really want to thank is that the participants who are members of the Canadian Longitudinal Study of Aging, many of you gave data that really is informing some of the solutions. Both McMaster University and the Jaravinsky Foundation also supported really important research on vaccines, keeping people active and healthy, and hopefully this will lead to new solutions. So thank you to the many CLSA participants that are here tonight. Without you, we wouldn't be answering these important questions. So on the stage, we're joined by Dr. Zain Chagla, Dr. Chandrima Chakraborty from McMaster University, and André Picard from the Globe and Mail, from the big city. So first, I'd like to introduce Dr. Zain Chagla. Many of you came up and said hi to him. He's available for autographs afterwards. He's an associate professor in the School of Medicine at McMaster. He's an infectious disease physician, and he's the medical director at St. Joseph's Hospital in Hamilton. And he contributed both locally, provincially, and federally, and to several clinical trials with COVID. He has published work on COVID-19 research, epidemiology and testing, and infectious control. So he's going to give us the pandemic from the front line perspective.
Perfect. Hi, good evening, everyone, and it's an absolute pleasure to be here. Thank you for the invitation to come, and I'm going to keep my comments relatively brief for the sake of making sure that we have a good amount of time for the generative discussion. These are my perspectives from the front line, and I think we need to understand what happened in this last 2 years to understand how we move forward with this pandemic, to understand what areas are still lacking, and to build that capacity. As you know, nothing is predictable, and this pandemic has been incredibly humbling, but recognizing, as things change, how do we rapidly evolve and continue that effort to make sure that everyone is protected appropriately. This is a study that was published in the Open Safely database. This was a large cohort study that was done in the United States. And this was relative risk. So what increased risk do these conditions have for severe COVID outcomes? And we can see things here like diabetes, ethnicity, liver disease, organ disease, transplant. But I want to take people to the very top here, because we underestimate, and realistically, the largest and most predictable feature for people and their deterioration from COVID-19, how individually they suffer from this disease, is age. And it is not a small margin. 80 is way, way out here, the highest of any risk factor out there by a significant degree. And even between 70 and 79 is still higher than things like an organ transplant, like rheumatoid arthritis, other immunosuppressive conditions. And I think when we hear about the stories of prevention of the most vulnerable populations out there, we think about people who have cancer, we think about people who have chronic kidney disease and diabetes, and certainly they are important risk factors to note. But on top of the list, by far, still remains age. And we heard today through a number of the talks about some of the issues along with age and vaccinations and other issues. But I think we really need to pivot and focus as we move forward. First and foremost, the hierarchy of who needs to be prioritized for any intervention in this pandemic moving forward is age. And it really has shown in a number of different studies. In July of 2020, there was a big controversy in the scientific world around the pandemic control strategies moving forward. In July of 2020, we had a number of groups that were coordinating different efforts and different philosophies of pandemic management. This was after the first wave. There was no foreseeable vaccine, although lots of development in that context. And people had been scarred by what had happened with the lockdowns and everything moving forward. And there were two factions really that showed up. One was the Great Barrington Declaration, going back here, the Great Barrington Declaration. These were a number of epidemiologists that met in the United States that came up with a novel pandemic strategy of protecting the elderly and vulnerable, and essentially letting everyone else kind of deal with the infection on their own, and that pandemic control would come with natural immunity with the population. And the other was the John Snow memo, which was kind of a counterculture of, what we really did realistically was making sure that everyone is protected, using controls in the population to make sure the virus doesn't spread aggressively, and that, there was not really pathways to protect everyone, certain groups individually, considering how, widespread the virus was over time. And I think the Great Barrington Declaration, much of it did not amount to anything other than more suffering. But one piece that they really emphasized, which I think got lost in the rhetoric of this debate, was focused protection and making sure that the highest risk individuals have the highest priority of protections in order to mitigate the disease as much as possible. It didn't mean that lower risk individuals, and certainly we saw this from the front lines, especially in the second and third wave, of younger individuals, some without any medical issues, showing up in our hospitals, showing up in intensive care, and suffering from the disease the most. But age was still the predominant thing we saw on the wards. And again, that protection in that organization. And some people say, well, it wasn't possible. I'll bring up this example from British Columbia and Ontario. And this was a comparison that was done in the Canadian Medical Association Journal of pandemic strategies in British Columbia and long-term care versus Ontario and long-term care. And there were a number of different interventions that BC put up front. One of the first community-derived cases in British Columbia was actually an individual that worked in long-term care. So British Columbia was very aware of the liability in long-term care very, very quickly. And they instituted a number of measures: dedicated IPAC, very easy access to testing, and probably the biggest strategy that's underestimated is individuals working at a single workplace. And so that would mean PSWs, nurses would stay at a single long-term care facility to mitigate if one were to go an outbreak, then they wouldn't necessarily bring it to another long-term care facility. And knowing the incubation of this disease, it's almost too late sometimes when they discovered there was transmission occurring. And you can see here just the benefits here. And if you look at the percentages, which is the most important part, obviously British Columbia has a lower population than Ontario, and looking at cumulative numbers isn't perfect. But if you look at the resident infection rate, it's just outstanding what British Columbia did. And this is with very few tools other than testing, infection control, early surveillance and mitigation. And they were able to take the resident infection rate from 7.6% in Ontario to 1.7%, and really, really remarkable in that standpoint. I think this was one of the first lessons learned here is that, again, as we move forward with this pandemic and future pandemics, strategies in congregate care facilities are going to be paramount to making sure that the most vulnerable are protected, especially as we know that many of the infections to come are going to disproportionately affect the elderly and are going to disproportionately affect people who live in congregate care facilities. And I think we knew this from the front lines as well, from our experiences in hospital, and it wasn't all just COVID that brought people into hospital. It was the complications of staffing crises and other issues in long-term care. We're standing in Hamilton. Hamilton, is also known for being the first city in Canada to completely decant a long-term care facility into its hospital. And for those of you who remember the Rosalind, it was a remarkable act. There were incredible clinicians, nurses, and people on the ground, paramedics, to make sure that these patients, COVID or non-COVID, were cared for. But it was, a tragedy for those individuals that lost their homes as part of COVID, that had to live in a hospital for months until they were rehoused. And the complications of not only COVID, which many of them survived, thankfully, but also the complications of that social isolation, that loss, that instability, especially at a vulnerable point in their lives, cannot be discounted moving forward. And again, reinforcement of congregate care facilities has to be a priority moving forward for infections, but other reasons. And I think we saw paramedics, we saw some of the reports from paramedics nationally of the military nationally that assisted in certain long-term care facilities in the GTA and in Quebec. And again, we saw not only complications from COVID, but complications from neglect. And recognizing that, again, in a staffing crisis, in a heartbeat, this could happen again, and we do have to make sure it's mitigated. I will say vaccinations have changed everything. This is a diagram from my colleague Nathan Stahl, who is very involved in Ontario and the long-term care crisis. And you can see here, this is COVID cases, long-term care outbreaks from September 1st of 2020. And we see just, again, going into the winter before vaccines were available, just a rise in long-term care outbreaks, a rise in long-term care deaths, and cumulative cases. And then all of a sudden, as vaccines start going into long-term care, this curve just drops. And it's astounding because this period from January to March of 2021 was the third wave. This is when our hospitals were filled. This is when our ICUs went into crisis. This is when we saw outbreaks in other facilities. But vaccines changed everything in long-term care. And I think we as we talk about vaccine strategies moving forward, we have to reflect on how much they protected that population. And one of the wisest moves in this pandemic was to make sure they were the first to be vaccinated, as they were the most vulnerable groups out there. But when we talk about the strategies moving forward, I think we have to recognize that not all elderly are at the same risk. And the way we implement vaccines has to take into account strategies such as reaching new Canadians, Canadians that don't speak English very well, Canadians that are in communities that are vulnerable and poverty, and this applies to elderly populations. And so you can see here, this is when the vaccines were largely available, 2 doses were largely available in August of 2021. Neighborhoods of refugees, 80 plus, we see a 56% vaccine rate. In neighborhoods with very few refugees, we're seeing the same vaccine rates in people even 16 to 39. And an incredible discrepancy here, recognizing that these 80-year-olds are the highest risk of complications from this infection. Some of it was supply, but at this point supply was there. Some of it was outreach. And there has been a lot of work done to make sure these communities have been reached, that vaccines made it to these individuals, that community ambassadors were there. But some of that infrastructure is now gone. And as we move forward, as new vaccines come to the market, how are we going to make sure that these communities are still reached first and foremost? These elderly in these communities are reached first and foremost moving forward. I don't have the answer to that, but I think this is a big question moving forward. We see, this is looking at material deprivation, so income. And we see the same thing in income, right? In 80-year-olds, there is a drop in vaccination at the lowest incomes. And this includes boosters. This is actually recent data from February of 2022. Similarly, in 60 to 79-year-olds, we see this drop. And they were reached by 2 doses of vaccines, which is the solid bar here, but 3 doses of vaccines are actually lacking in these communities in that sense. And so again, we really do have to think, as we talk about vaccine strategies moving forward, it's not simply that elderly are at the front of the line. Of course they are, but how do we make sure that vulnerable elderly that are living in poverty and homelessness, and those in communities that are at higher risk, vulnerable communities, are also reached? And one would argue that the benefits in that population are much higher than vaccine uptake in younger populations, recognizing just how much that disease affects people that are elderly. This is data from Portugal. And Portugal, for those who are paying attention recently, is being hit by another COVID wave of a new variant of BA4, BA5. They're actually just coming through it at this point. There wasn't a significant health system strain, but there was certainly a fair number of hospitalizations associated. And again, we see this age and vaccine spectrum being the big piece. So the elderly, those over 80, those between 70 and 79 are at the highest risk of hospitalization. That vaccinations, 2 doses versus 3 doses, mitigate that risk. These are risk of hospitalization data. But there is still some vulnerability in people that are vaccinated. The other thing I will point out, though, is Portugal is one of the most vaccinated countries on earth. There was an article in the New York Times, I think in September or October, that talked about there was no one left to vaccinate in Portugal. The booster uptake rate has been higher than many other European countries. And so the question is this recent data, this is April to June of 2022, why are there still 80-year-olds that are unvaccinated? Knowing that this disease is rapidly fatal. There is a 12% hospitalization rate and about a 5 to 6% mortality rate in this population. It's not a big population that is unvaccinated, but why is there still a population unvaccinated? And again, these are questions we need to ask as we move forward with this, targeting those populations, understanding those elderly populations that do not get vaccinated. What is the reasoning behind it, and what can we do to target those people more aggressively? Even if it's 1% of the population, if 1% of the population gets COVID all at once, it's a huge health system strain when that happens. And again, these are preventable deaths and preventable hospitalizations moving forward. Much of my work recently has been in COVID therapeutics. In Hamilton, we've been very proud of being one of the largest therapeutic clinics in Canada to help patients, giving them antivirals and monoclonal antibodies to prevent severe complications of COVID-19. These are therapeutics that work well in vulnerable populations, but unvaccinated populations as well. And I think, again, we see this. This is data yesterday from the MMWR in the United States by zip code, and we see the same thing, that high vulnerability communities, high vulnerability zip codes are the ones that access therapeutics the least as compared to low vulnerability zip codes. And in fact, if you look at this diagram for access points in communities, they're actually highest in the highest vulnerability zip codes. So the access is there, the providers are there, pharmacies are available in the United States to prescribe these drugs, but patients aren't seeking access. And I think, again, these are big points to understand, recognizing, that these communities are the ones that are going to suffer the most, as we see, as poverty is such an underlying risk factor for complications. Finally, talking a little bit about long COVID, there's been a lot of discussion around long COVID in high-risk populations. Again, and the approaches in elderly populations are going to be very different. Especially in younger populations where we're using things like rehabilitation, counseling, experimental techniques to really target things. The younger populations are able to participate in this. They're able to, be more two-way conversational, to understand biofeedback and other modalities. How do we deal with long COVID in populations that have cognitive impairment and dementia? How do we define that, right? Is it a worsening of their dementia? Is it a worsening of their functional status after COVID? And as we know in the geriatric population, acute illness can certainly take people far away from their baseline even when they recover. And so again, we haven't really discussed, how we assess long COVID in elderly individuals, especially ones with other, underlying medical conditions, and how do we make sure that they're offered resources, supports, and services, and especially as we get therapeutics, how does that really engage in that population? Finally, I will not end without saying that this is a global disease. This is modeling that was done from a colleague in Australia of the infection fatality rate amongst those living in low-income countries versus living in high-income countries at the same age. There is a biologic process to this disease, but at every age group, you can see that low-income populations globally suffer more. We don't hear about it because it's not necessarily, statistical methods and reporting is very challenging in low-income countries where health services are poor. But we, do need to think about these strategies moving forward for pandemic control in low-income populations, because our global elderly are suffering more than, our global young, and again, they're populations that are often left out as part of these strategies moving forward. So I want people, as my last note, to think about this. This was news published yesterday from Moderna, June 22nd, about a bivalent vaccine that is targeting the newest variants that are coming, BA4, BA5. There's a lot of, enthusiasm here. But this is probably going to be a vaccine that's going to take some time to be approved. There's going to be supply chain issues. There's going to be a huge global demand for this vaccine. And so when this finally comes to the Canadian market, how are we going to implement this, recognizing the populations that are the most vulnerable? And when this comes to the market, how are we going to implement this, recognizing globally the populations that are vulnerable? And I think, we haven't answered all of these questions yet. I hope that we, when we have limited supply of this drug, that we make sure we administer it to the people who need it the most. But I'm a bit afraid that these discussions are not happening now, and really, making sure that strategies to use income, recent Canadian status, and focusing on global vaccination strategies are really being incorporated now. And I hope we start these discussions moving forward. Thanks.
Thank you so much, Zane, for that really informative talk. And I can remember at the beginning of the pandemic when I was covering the wards, lots of those over 80. The wards were like a ghost town. The nurses were all huddled in their nursing units. There were no families in the hospital. Very frightening for those over 80, and especially when English wasn't their first language. People were afraid to go into the rooms. It was traumatic not only for the patients, but also for the families. And I hope we never experience that again. That was probably the hardest part when I was visiting as a geriatrician. So I'm really delighted. Our next speaker is Chandrima Chakraborty, Chakraborty, and she is a professor in the Department of English and Cultural Studies. She's the director of the Center for Peace Studies at McMaster. She was awarded the University Scholar at McMaster, and she was elected to the Royal Society of Canada's College of New Scholars, Artists and Scientists. She is a leading scholar on relationships between race, racism, and pandemic, focusing on South Asians and East Asian Canadians. So delighted and looking forward to the talk.
Thank you. I am really humbled and honored to be able to speak beside these very eminent panelists who have way more expertise in this topic than I do. So looking forward to learning from them. I always see Zain on TV, so here is a celebrity, so even more honored to sit beside celebrity. I also read a lot of Andre's work, so I am in the midst of celebrities, so that's wonderful. And I also want to thank MIRA and Nexus for inviting a non-specialist like me on this panel. So I'm a cultural studies researcher with research interests in nationalist history and public memory. And I'm hoping to add my voice to what many, many others have noted, that racialized communities in Canada are suffering disproportionately from the pandemic's two viruses, COVID and racism. And to get there, I will begin by briefly tracing two trajectories of my research. Today is June 23rd. I don't know if it means anything for anybody in this room, but to the families of the 329 families on board Air India Flight 182 who died in that plane crash on June 23rd, 1985, it is a day seared in their memories. Air India Flight 182 left Toronto and was on its way to Delhi, India. It had luggage bombs in it, which detonated close to the Irish coast, killing all passengers and crew. There were 280 Canadians on that plane and 82 children under the age of 13. It was the largest aviation disaster of the time, and it continues to be remembered as Canada's largest mass murder and the longest and most expensive criminal investigations in Canadian history. The bombing was initially dismissed as a foreign tragedy, and there are multiple reasons for that. One, it was an Air India flight, not an Air Canada flight. The plane did not crash in Pearson. It crashed far away from Canadian soil, close to Ireland. And the most important thing to me, because it was filled with brown people. And at that time, they were seen as foreigners, and it allowed Canada to distance the tragedy from its, any discussion in terms of public history, public memory, national history. It was characterized as an act of terror committed by Indian immigrants who had imported their animosities from India to Canada, even though the bombing was planned in Canada, executed in Canada, and most of those who died were Canadians. Much later, in 2010, there was a public inquiry and a federal government apology that acknowledged Canada's failures to prevent the bombing and the mistreatment of the families in the aftermath of the bombing. My work for more than a decade has been dedicated to educating Canadians about this little-known, little-remembered tragedy, so-called Canadian tragedy. Issues of structural inequities, such as security negligence, the failure to take seriously warnings about the attacks, or indifference or inadequate response to the loss of mostly brown lives, propel my Air India research. And I see many, many resonances with the current crisis, the global pandemic. Both the Air India tragedy and the pandemic point to a crisis in Canadian multiculturalism. Both carry long-term consequences for racialized communities, and both call us to transform our societies by attending to the pain and suffering of marginalized communities. Some of the inequities that the Air India tragedy and the pandemic have so glaringly brought to the surface are inequities that have long legacies, but they're only visible to those who encountered them, and some encountered them in their everyday. Just like many of us here who do not remember June 23rd, and yet there are others in our midst who just can't forget that date. Underpinned by my research on the Air India tragedy, my more recent research has focused on the pandemic. With COVID-19, I have personally experienced the loss of lives of grad school friends in India, in Delhi and Chennai. And like many immigrants, I have witnessed firsthand the effects of social isolation on my aging parents who live in India, and older adults in the community in Hamilton that I now call home. I have been also troubled by the rise of anti-Asian racism in Canada, including Hamilton and the Greater Toronto Area. And all of these multiple threads of belonging to different places and the relationships that I have formed with others have directed my research towards examining race, racism, and the global pandemic. And along with it, the role of South Asian advocacy groups in COVID-19 mitigation in Ontario. I think that a cultural studies and a community-engaged lens can offer us some ways into understanding and responding to COVID inequities and pandemic racism. I want to propose that in order to make our existing systems and structures more inclusive and more responsive to the needs and experiences of racialized groups, we will have to lean into each other as researchers and community members. As a cultural studies researcher, I'm trained in the art of close reading, texts, and by extension, bodies and spaces. And I hope to draw upon these skills to talk alongside with communities and other experts in health and medicine. For example, my analysis of surveys, media coverage, and polls on Asian communities during the pandemic makes the differential effects of COVID and associated racism on aging East Asian populations explicit. We know that in Canada, as in the US and globally, the COVID-19 virus was promptly attributed to Chinese Canadians. And in an undifferentiated racism, other Asian Canadians have been seen as bearers of disease as well, and often made targets of harassment and violence. In June 2020, a national survey conducted by the Angus Reid Institute in partnership with the University of Alberta suggested a shadow pandemic of racism that exists in Canada, as half, 50% of Canadians of Chinese ethnicity surveyed reported being called names or insulted as a direct result of the pandemic, and 43% said that they had been threatened or intimidated. One finding was that 61% of Chinese Canadians adjusted their routines to avoid run-ins with racist comments or attacks. Similarly, a June 2020 survey of Chinese Canadians by the Globe and Mail showed that 6 in 10 respondents adjusted their routines to avoid racist attacks or unpleasant encounters. After a year into the pandemic, the Angus Reid Institute did another survey in May 2021, and they found that 58% of Asian Canadians surveyed had experienced at least one situation related to anti-Asian discrimination in the last year. 1 in 5 Asian Canadians said they had consistently changed their routines or behaviors to avoid uncomfortable or dangerous situations. And similar findings have been reported by Statistics Canada, Chinese Canadian Council for Social Justice, Canadian Race Relations Foundation, etc. Now imagine what this means then for aging Asians. What does this mean? Aging Asians who find themselves at a greater risk of infection because of age or comorbidities, and at a risk of facing hate attacks. The cumulative burden of experiencing discrimination, viewing media coverage like the ones that I showed you, or some of the surveys that I showed you, the burden of that has the potential to exert significant negative mental health effects on aging populations. Research already points to cultural values that de-emphasize psychological explanations and solutions for emotional distress as a major factor for the low utilization of mental health services by Asian Canadians, East Asians, as well as South Asians. And this is concerning given the finding from researchers based in University of British Columbia and York University who surveyed and studied Asian Asian Canadians between March and April 2020. And they found that East Asian Canadians face a disproportionate mental health impact of the pandemic. They found that higher incidences of acute discrimination encountered by East Asian Canadians during the pandemic explain their higher levels of mental health symptoms as compared to white Canadians. But the effects of anti-Asian racism may not be limited to Asians alone. And think of 9/11 as an example. We saw this after 9/11, where increases in the perception of discrimination after 9/11 were not only found within Arabs and Muslims, Americans, but also among other minorities. Some of you might remember that the first folks who were attacked, killed, as well as pulled out from Amtrak trains for questioning, were turban-wearing Sikh men, South Asians, not Arabs, not Muslims. So again, what I'm trying to say that there's a spillover effect that happens. So once when one racialized community feels attacked, those same fears of persecution arise in other minorities as well. And I saw this concern in my own South Asian community with the emergence of the Delta variant, which was reportedly first detected in India, right? And the concern was that the racism against Chinese Canadians or East Asian Canadians might now be directed to South Asian Canadians. Along with impacts on psychological well-being, recurring episodes of discrimination undermine minority groups' sense of belonging to Canada. Racism creates a deep sense of apprehension within racialized communities who carry and will carry post-pandemic memories of these events. And these traumatic memories are also often passed on to the next generation. It will therefore be critical to ensure that we listen to affected groups, address their needs, and remember the experiences of anti-Asian racism in our memorialization of the pandemic, because psychic scars and community memories of racial grief lingers. And here again, I'm reminded of the lessons from my Air India tragedy research, where the loss of lives were understood as a localized loss, as a loss of the Indo-Canadian community or the South Asian community at best, not a loss worthy of national public mourning in Canada. Unlike the Air India tragedy, with the pandemic, we found all our lives disrupted by the same event at the same time. True. However, the risks and the effects of the pandemic were distributed unevenly. Therefore, our remembrance of the pandemic has to acknowledge the differential impacts of the pandemic. Think of aging communities again as an example, which is only one section of our population. But even within this demographic, some were at a greater risk of being infected than others. Older adults with comorbidities, older adults who had family members employed in essential services and therefore had to leave home to work, or those who had less opportunity to isolate because they were living in cramped quarters, right? Again, tied to economic class, or in multi-generational housing because of cultural values and practices. Many older adults are already victims of socio-cultural isolation due to limited linguistic competence and lack of adequate social networks. They seek out social spaces where people of similar culture and language congregate. And these spaces were completely shut down with lockdowns. And aging populations became more dependent on the generosity of friends and neighbors as they were trying to follow public health mandates. And this has added to pre-existing negative representations of aging communities as aging tsunamis. Tsunamis are great walls of water that destroy everything in their path and leave behind destroyed lives. Such damaging language to represent aging populations needs to be discarded because language matters. Metaphors shape the way we think about others, and such thinking shapes our responses to them, whether it's Chinese virus, whether it is Wuhan virus, or whether it is aging tsunamis. Rather than the specter of aging populations as anxiety-inducing, we need to center the experiences and insights of aging populations to improve healthcare delivery and to build trust in the system. When people need support and they don't get it, It does not help to build trust in public agencies and public policies. And we have seen this again and again, not only with the official response to the Air India tragedy, but with the failures to listen to the perspectives of Black and Indigenous communities. We need thoughtful, collective, structural responses to address the many structural inequities that affect the health and well-being of marginalized communities in Canada, which COVID has helped to bring to light. For example, the South Asian COVID Task Force was formed by medical professionals coming together to advocate for South Asian communities in Ontario and BC and to fill gaps in public health delivery. When reports about South Asians being resistant to vaccines or not following vaccine mandates emerged in the media, South Asian COVID Task Force began translating public health messages in accessible infographics and in multiple Indian languages, South Asian languages. They used media platforms, not Facebook, but WhatsApp, again, a particular media platform that is specific to that community. So they used media platforms such as WhatsApp to reach the South Asian community. Rather than CTV and CBC News, they started showing up in Punjabi and Hindi radio shows, right? Again, to translate those messages in a language that was accessible to aging community members. And they started educating South Asians about hand washing, masking, vaccines, etc. And they've played a critical role in getting vaccine clinics set up in banquet halls, right? Again, something that South Asian communities go for, weddings and baptisms, etc., and in places of worship, gurudwaras, mosques, and temples. So again, places that are familiar and familial to South Asian, elders. So we have to learn from and partner with advocacy groups such as the South Asian COVID Task Force, Canadian Muslim COVID Task Force, Black Scientist Task Force on Vaccine Equity, and others that have been at the forefront of COVID mitigation. As researchers, community members, and Canadians, we can learn from our collective failures and our successes to be better prepared for the next crisis, whether the Tehran plane crash in 2020 that killed many Canadians and was embraced promptly as a Canadian loss, which I see as a step in the right direction, a response informed by the lessons learned from the mistreatment of the Air India families, or whether it's the next infectious disease threat. And we can learn, unlearn, and learn anew by drawing upon different voices to offer a holistic response to a crisis that affects us all, while being always alert to how some had to bear a much heavier burden than others. We have to hold space and be alert to who is not in the room and why, and draw in the voices that we know are not in the room. And this might prompt us to dislodge ourselves from our vantage points and in collaboration, create innovative responses. My heartfelt thanks once again for this wonderful opportunity to think alongside with those in this panel and with many others who are in this room. Thank you so much.
Thank you very much, Chandra. What really struck me is when you said that the trauma of this generation, what they've gone through, the social isolation, the discrimination is passed on to the next generation, and how can we change that story? We've certainly heard that with the Indigenous population and what the trauma that they've encountered. So I think that that was very, very eye-opening. Our last speaker tonight is André Picard. André is the health columnist at the Globe and Mail and author of 6 books. For those of you who have had a chance to read his current bestseller, Neglected No More, The Urgent Need to Improve the Lives of Canada's Elders, it's a very impactful book, and we're really looking forward to hearing you say more. He's received acclaim for his writing, and he's been named Canada's top newspaper columnist last year. He received the Stanford Fleming Medal from the Royal Society of Canada for his outstanding contributions to science communication. And I can tell you, many of us in academia at McMaster and other universities spend tons of time trying to learn about knowledge translation, how to get our research out to you. You're the master. we can learn. So delighted, and he has many other awards. He's got many more doctorates than any of us academics do. So welcome.
Well, thank you for that very kind introduction. I'm the non-academic on the panel, so I don't have any PowerPoint. So I'm just going to talk. So no group in Canadian society has been harder hit by the COVID-19 pandemic than our elders, especially those living in congregate settings. It's hard to really put into words the extent of the carnage that occurred in long-term care and to a lesser extent in retirement homes in Canada. There have been about 42,700 pandemic deaths to date in Canada. I just checked the stats before I came over. And about 21,000 of those deaths have been elders living in institutional settings, more than half. And most of those deaths were front-loaded. They happened in 2020, 2021 before we had vaccines, which we heard about have been really life-saving. Now, most of the rest of the people who died have also been elders. About 80% of deaths in Canada have been people over the age of 65. Now, the direct COVID-19 deaths, those are the ones that are easy to count, but there's also a lot of collateral damage. We may never know the extent of the impact of loneliness and isolation that are the byproducts of some misguided and harmful policies that we had, such as shutting out essential caregivers from homes. These policies were well-intentioned, but they were wrong-headed and they were deadly. I, like many Canadians, lost a loved one during COVID. He didn't die of COVID. He died of loneliness. He was in a care home, very good health, playing tennis 4 times a week, going to church every day, and was locked down for 5 months. He died of deconditioning, of being alone, of not wanting to live anymore. That's the reality. We can't count those deaths, but there are many of them. Now, many people dismiss the COVID deaths in older people as irrelevant. They were going to die anyhow. I can't tell you how many times I've heard that. It's a common refrain to dismiss our failures. I find that attitude reprehensible, and doubly so because it's not true. Many, if not most, of the deaths were preventable, and we can't forget that. COVID-19, at the very least, accelerated and made worse the way people died. Older people should not be treated as disposable, and they were during COVID-19. Mortality rates in long-term care homes, they're normally high, 1-2% a month. People are old, they're at the end of life. But during COVID, those numbers were 10, 20, 50%. Some homes were decimated, 60% of residents dying within weeks. But the way people died was even worse, mostly alone and without palliative care, without their families, scared, alone. You know, the hardest place to get palliative care in Canada is in a long-term care home. Only 6% of people get palliation. It makes no sense. These should essentially be glorified palliative care facilities. We had policies in this country that explicitly said residents who fell ill with COVID should not be transferred to hospital. Instead, they were sedated with massive doses of morphine and left to, quote unquote, die peacefully. Some long-term residents died of starvation and dehydration. This happened in Canada in 2020. Again, there are no words for this, and there's no excuse. Now, perhaps the most tragic aspect of this story is that it was also predictable. The way most care facilities are built and staffed and managed created the ideal environment for the spread of an infectious disease, especially a respiratory disease that preys on the heart. We know that your heart gets a little weaker as you get older. I know mine's gotten a lot weaker in the last couple of years, covering COVID every day. We also had ample warning of what was coming. Countries like Italy and Spain have massive deaths of elders before we had a single death in Canada. Our first death was on March 7th, 2020. There had been thousands of deaths in Italy and Spain by then. But in Canada, we sat on our hands. We refused to look at this evidence and respond. We didn't put an iron ring around our care homes, as some premier famously said. We didn't even put a paper ring. Heck, we didn't even provide personal protective equipment to people living there and their staff and their families. We chose, again, quite deliberately, to put the ramparts around our hospitals, not around care homes. Hospitals did tremendously well in Canada during COVID because we had policies to prevent it. But that wasn't good enough. Now, we fretted a lot about cruise ships at the outset of the pandemic. I don't know if you remember that. We were obsessed with cruise ships. But we failed to register that care homes are really like cruise ships, without the Bermuda shorts and the fancy buffets, of course. But they're places where disease spreads really, really easily. And you know this all too well in this audience. Thousands of people in congregate settings die of infectious diseases in normal years, and that means before COVID. Influenza, pneumonia, hepatitis A, norovirus, and so on. We accept all this as normal. You know, a lot of people said to me, hey, you know, they would have died anyhow. They would all die of the flu every year. And it's true, there are a lot of flu deaths in congregate care. But that should prompt us to ask the question, why do so many people in care homes die of preventable infectious illnesses? Not to dismiss it. Now, the larger problem is that the neglect of elders is systemic. Ageism is built into our public policies. It's baked in. During COVID-19, we reaped what we've sown for many years. Now, during the pandemic, as you heard in the introduction, I wrote a book called Neglected No More. Now, this is not a book about COVID. COVID was just a launching point to look at the systemic issues that were exposed. Now, the important message of the book is that as bad as elder care is, and it is bad, it's fixable, and it's affordable to fix it. To me, the biggest change required in our society is philosophical, a change of attitude, if you will. We have to stop catastrophizing aging. We have to dispense with terms like the gray tsunami and other expressions of age-based nihilism. The way life expectancy is increasing is a marvel of science, of medicine, and social policy. The fact that the fastest growing demographic in society is centenarians, people over 100, that should be celebrated. It's a tremendous achievement, and it's come very, very rapidly. But we haven't adjusted our attitudes. You know, the vast majority of people living into their 80s, 90s, and 100s are relatively healthy, and they're active. I have the luxury and the pleasure in my life of talking to a lot of them all the time. People like my uncle, 93 years old. He complains that, he tours with a Dixieland band, and he complains that his band is so busy he doesn't have time for sailing and tennis. That's the reality of many older people. It's not people in homes. They're a very small minority. But we don't make it easy to age gracefully. Right now, once people get a little old and rickety, our default is to put them out to pasture. And these pastures are not very green. They're big buildings by the side of highways where everybody just drives by and doesn't dare look. In this country, we have 400,000 elders living in institutional care. Now, that's about 7% of people over 65, a small minority, but still one of the highest rates in the world, about double the number of people in care homes in European and Nordic countries. We practice elder apartheid in this country. We yank people out of the community and we put them in homes that look like prisons and smell like toilets. Not to be too cruel, but I visit a lot of these homes. Out of sight, out of mind, and ignored by policy and politics. Our priority should be to keep people in the community as long as humanly possible, not to strip them of their citizenship and their sense of belonging. The right care at the right place at the right time is the proper formula for health care, and especially for elder care. Because, let's be honest, the vast majority of care goes to older people. And that's not wrong. That's how insurance should work. We pay in our whole lives, and then we reap the benefit when we need it. So stop blaming people for getting old and getting sick. That's the normal way of life, and we should just adjust for it, and we haven't. So how do you keep people in the community? Well, first of all, you need a robust home care system. We don't have that. We need adult daycare, respite care for the hundreds of thousands of caregivers who give of their time and sometimes their lives. Subsidized housing for seniors, community-based programs, senior-friendly design and architecture of our cities and buildings. All this is doable. For every $20 we spend on home care, we spend $80 on institutional care. We've got that backwards. Makes no sense. People often end up in institutional care for the most banal reasons imaginable. They have trouble feeding themselves. They're frightened to walk on icy sidewalks in the winter. These things are easily fixable, and we can keep people at home. But we seem to funnel people towards the most expensive, inefficient, and unwanted solution. Let's not forget time and time again what public surveys tell us. More than 90% of people say they never, ever want to live in a care home. Many of them say they'd rather be dead than go to a nursing home. Now, they're not that bad, to be honest, but we should understand that message, and our policies should reflect what people want. Before COVID, people were skeptical about long-term care. Now they're downright frightened. And for some reason, but as I said, they're not as bad as people think. Now, of course, some people will need care homes. There's no question for that. For example, people with advanced dementia who wander, people like my dad. But we need to make that the last resort, not the first reflex. Just as importantly, care homes should look like homes, not like prisons. And by the way, there's a reason they look like that. Long-term care has its roots, it has its origins in the penal system, where derelict elders were placed and made to work for their gruel, quite literally. This type of home existed in Ontario until the 1960s. This happened in my lifetime, that this system existed, and we haven't adapted it. We haven't made it part of the healthcare system. It's an orphan sitting out there on the edge, underfunded and neglected, and no one really wants to look at it. And we have to make it part of the journey of care. Care homes should also be built purposefully. What does that mean? Well, they should have wide corridors that accommodate wheelchairs. They shouldn't have, many of you have visited care homes, we call them horridors, these narrow, long hallways that look like you're headed towards hell, if I can put too fine a point on it. They need things like figure-8 walking tracks for wanderers with dementia. People like dementia don't like to come up to walls. Give them a figure-8 track. That's what good homes do. People need safe access to the outdoors. That matters to quality of life. In Finland, it's the law. Everyone who's in a care home must have access to the outdoors, and they must have a window. These are simple rules that make life better. Ideally, people should also be active participants in their activities of daily living, not passive recipients of assembly line tasks. You know, we make a lot of people immobile because it's easy, but it's not a good life. Again, when I visit care homes in places like Denmark, even people with dementia participate in making their meals. They have a purpose in life. They don't just sit there and are treated like widgets. And of course, homes for people at high risk of infectious disease should be designed and built in the way to minimize these risks. Not 4 or 5 people in a room. We know from the statistics that's who died. People died in homes with multiple beds, with poor ventilation. Basic things need to be done to keep people safe. 1 bum per toilet, that should be the law. Keep people safer. Decent ventilation, the ability to isolate when there is an outbreak, routine use of personal protective equipment, a long list of simple things that we know saves lives. Now, you can provide care in a large institutional setting, but a home-like setting is so much better for workers and for recipients of care. And you know, there's a saying out there in the field, the conditions of work are the conditions of care. We really have to take much better care of our workers because they can't operate in the current conditions. Personal support workers being paid $13 an hour to do the most intimate, back-breaking care imaginable. No wonder no one wants those jobs. Proper staffing ratios, standards of care. You get about 2.67 hours of care, of hands-on care in a care home in this province. It should be minimally 4 hours. And the research from 20 years ago tells us that 4 hours was the minimum, which much sicker patients today, it's probably more. We can't just leave people festering all day in their beds, which is, again, too much of a reality. We need proper staffing ratios, the right workers in the homes. One suggestion, again from research, 55% PSWs, 25% RPNs, 20% RNs. It's actually hard to find a nurse in a nursing home anymore. We need ratios of 1 to 5 maximum, not 1 to 20, 1 to 180 at night in some homes. That's not proper care. It's not safe, and it's not sane Care homes should not be pseudo-hospitals without a fraction of the care provided in hospitals. We have to find the proper balance between providing medical care and providing a home. We also have to allow people to have some risk in their lives, not just stick them in the wheelchair because it's safer. Allow them to walk around, maybe even if there is the risk of falling. The trade-off is having a life, it's having a quality of life. And we don't have that balance right. Again, I want to stress that we do have a lot of good care in this country, but lots and not all is not good enough. You know, there are all kinds of excellent models to improve. Butterfly care, the Eden Alternative, Dementia Village, and so on. Many solutions are already out there. We just have to adapt them. What all these models have in common, what all the good care homes have in common, is putting the person at the center. The other thing they tend to have is, the other thing, unfortunately, we have in Canada that's common is that our care is unaffordable to many. The bills can range from about $2,000 a month to $15,000 a month. This is not covered by Medicare. You essentially have to be destitute to get so-called free care in a care home in Canada. This is a 16th, 17th century attitude, homes for the destitute. And the less you pay, the worse your conditions. You live in a room with 4, 5 people. Now, all this stuff I'm talking about, none of it is new. It's been recommended for decades, these changes. Nobody disagrees with the broader principles I'm talking about. Everybody loves their grandmother. Everybody wants them to be treated well. But we have to want what we want for our family, for everyone, regardless of what they look like, how poor they are, how wealthy they are. We have to have standards, and we have to live up to our values. But there's 2 main excuses for not acting. One is, I'm losing my microphone, sorry. Okay, I'm gonna hold. So two excuses. One is there's too much to do. This is all overwhelming. And number 2, it's too expensive. Neither of those things is true. We spend a lot of money on elder care already, about $14 billion a year. And there's no question after decades of neglect, we need to invest more. But we also need to spend the money we do more effectively, get value for money. And that starts with home care instead of long-term care, keeping people in the community, etc. Care should and must be affordable. You know, the basic principle of Medicare is that no one should be denied essential care because they can't afford to pay. COVID didn't break elder care. It was already broken. COVID just exposed the ugly truth. But if there's a silver lining in the pandemic, is that it's forced us to finally confront some of the glaring inadequacies. There have been about 150 public inquiries and government commissions examining the shortcomings of elder care in the past 40 years or so. So we know all the problems. We also know all the solutions. There are great recommendations in these reports. But we just have to stop dithering, and we have to start implementing. We don't need another royal inquiry. We just need to do what we know works, what works in other countries. It remains to be seen, though, if politicians and policymakers will act. The good news is we have many success stories in this country. For example, there are many long-term care homes that had 0 COVID deaths. Some had 0 COVID cases. What did they do right? Well, we know what they did. They had good staffing. They had person-centered care. They acted when the first case was detected. All this is simple stuff. Proves once again that most of this was preventable. So we have to scale up our successes and stop scaling up our failures. The final thought I'll leave you with is this one. Every one of us, with few exceptions, is going to be a caregiver and/or a care recipient. We owe it to ourselves to get this right, out of rational self-interest, if nothing else. So again, thank you for your attention. Thank you for coming out tonight, and I look forward to the discussion.
Thank you so much, Chandré, for that beautiful summary of the issues facing older adults and caregivers and health professionals in Canada these days. And when you say having the older individual in the center, it's really meaningful. I was quite struck when I went and visited Manitoulin Island with my colleagues in nursing and medicine. And we were all prepared, the nurse was prepared to do a whole talk on how to decrease physical restraints, tying people down either with belts or with drugs. And the nurses looked at us and said, "We don't tie anybody down." And we said, "Why? It's a big problem in our hospitals and nursing homes." They said, "This person is either my neighbor or somebody's grandmother that I know, and we wouldn't treat them that way." And I think that that's really important, is that the older adult is at the center of the care. So I'm welcoming everybody to either put up your hand, there's a roving microphone, introduce yourself, or come up to the microphone, and we're really looking forward to your input and your questions.
Good evening. First of all, thank you very, very much for having this. Thank you very much for all the staff who went above and beyond to get us through this at the hospitals, at the homes, scientists, everyone. And Doctor, I can't thank you enough. You were the voice of calm and reason every night that we tuned into. And that's important. If we've learned anything, is consistent, calm reassurance does help. To your point, thanks, yeah, a hand for all of you. To your point about the racism, I hate to say that when I was in Italy for a vacation, the pandemic broke out there and I was forced to stay. I saw the development of the whole pandemic from the Chinese virus into everybody. And sad to say that racism is alive and well there as well, because the sushi restaurant, the Chinese restaurant, a lot of the Chinese immigrants were really targeted there. And I really took exception to that, saying, do you know how many Italians left Italy and were welcomed in other countries? How can you do this? It's behavior, it's fear, it's a number of ugly things. And to your point about changing philosophy, COVID exposed where we're at in terms of our opinions or values about aging. If we don't value people, whether they're old or younger, if we don't put enough value into that, then we're not going to be able to respond when these things happen. We have institutionalized seniors faster than any other country. We've also experienced the largest economic growth post-war. Wealth equals neglect. Because for a country as rich as we are, we should have better things. But it's those countries who still hold on to those family multi-generational values that, in fact, that is part of the family. And as economic things become harder here, maybe families will stay together, because that is a good starting point. To put together a support system to pivot that fast during COVID was impossible. And in terms of response, if we learned anything, just to note, it was easier to get Domino's pizza delivered to my mom's house, who survived COVID at the Jaravinsky, so thank you to everyone there, than to get a family doctor to come to her door to check her lungs, even outside. Can I stand in the parking lot? Can I do something to get her to see you so you can hear something? No, we're closed. And that entire frontline service, where did that go? It disappeared, and the hospitals got annihilated. Thank you for listening. Bless you all. Thank you very much.
Yes, I just had a question from, I think, the very first slide that was showing the difference between British Columbia and Ontario. And at the bottom, there were two terms. One was mortality and the other was fatality. Now, as far as I can tell, they both mean you're dead. But I'm just wondering, there was a difference. So can you explain how you saw those differences?
Yeah, so the study was kind of looking, I think we Andre talked about it a bit. So the actual individual mortality per patient in those care facilities in British Columbia and Ontario were the same, right? If they got COVID, biologically they were on a course. But the percent mortality associated with these outbreaks was much lower in the British Columbia experience than the Ontario experience. That really is the limitation of cases, as the measures were put in place for personal protective equipment, dedicated staffing, et cetera, even in these outbreaks in British Columbia, the mortality rate, per outbreak was much lower in that context. The individual mortality was still high. Again, if people get COVID, there is a destined course. Unfortunately, in early 2020, we didn't have answers on terms of how to treat it. It was a bit of a mishmash. But when you look at the individual mortality from the actual care facilities down to the patient, when outbreaks occurred, they were much lower in British Columbian long-term care facilities in that sense. That was that difference. It is worded really poorly in that article. It does actually go through it a little bit better, but really reflects the mortality per outbreak in British Columbia versus Ontario, which was markedly different in that sense.
So fatality?
Yeah, the fatality per, I know there was crude mortality versus cumulative mortality versus cumulative fatality, but they define it a little bit differently in the text in terms of more the system versus the individual getting COVID in that sense.
Hi, thank you very much for a really interesting evening. One thing I didn't hear mentioned, and it falls to me, I'm a single person, have no family in town, so I live at home and I'm fairly active. But what I found a real detriment was trying to get information when you're not computer literate. I don't think that many people mean this, but I don't know how many times I got turned off or, we just don't know what you're doing. So you eventually give up and you sort of, I think it's a really challenging thing. People who have family, and particularly people who have grandkids, know this stuff. Mm-hmm. People like me who don't have anybody to call on, people who are answering phones, etc., just don't understand that you come from a different generation. Mm-hmm. I think that it's really important to know that. I think somebody mentioned that isolation was a real concern here. And those of us who were fortunate enough not to have COVID because we stayed in also really suffered from loneliness and isolation. I think that the one really bright thing that happened was that the library called any of us who had cards and said, can we help you? And we'll work the way through. But that was the only sort of bright light in the whole 2 years. So I just would wonder if that could be into some of the planning at McMaster Institute for Aging, et cetera.
Yeah, I think that's a wonderful comment. I know the YMCA also was calling their members, and some religious organizations were also certainly we've seen a huge impact with social isolation, to the point that sometimes we don't know, does the person have early memory changes, or was it due to lack of stimulation for 2 years and not talking to other people? You weren't even seeing the person that filled in your Tim Hortons coffee and said good morning. So that's really, I think, as a communication expert, what would your suggestions be? Not everybody was computer literate. Many people, and both of you, and yet we assumed everybody could register online for their COVID vaccines. Any suggestions or comments?
Yeah, I know, like in Hamilton, they hired vaccine ambassadors, so younger people who were helping the older adults to book vaccine appointments, because even to book the appointments was an onerous activity, because you had to go on the websites, and like many elderly people in the community, like I think of my parents, they would never be able to book a vaccine appointment on their own. It's impossible, right? As you just mentioned, it's from a different generation, and that generation has not been taught those skills, right? We are learning as we go, right? It's not like my son knows way more. If I have a problem with my phone, I just give it to him. Say, it's not working, right? Like, just do something and it works. When I try to do it, I'm swiping left and right and it doesn't work. So it's, it's the children who are more computer literate. And so for older adults, it has been a real difficulty. So digital literacy is something that, as you said, attention has to be paid to that. But in some cases, I think it is also not right to expect older adults to now pivot and scale up their skills to learn that, but there has to be assistance provided so that somebody can actually do the booking for them, or if it's, I know even in the community in Hamilton, many of us were just driving our, people in the community to the vaccine, clinics, etc. So I think it can't be all shifted onto the older adults and say, now learn how to use the computer, or now learn how to use, Twitter and TikTok or whatever it is. But those assistance has to be provided. So that's my sense.
Yeah, I think it's a symptom of a larger problem. The system is used by older people, and we have to make it friendlier for them. Mm-hmm. So there has to be a lot more human connection in our system, not just an answering machine or a website. So we have to do that. Navigation has become really, really important in a complex system that we have. So we have to bake that into our everyday care. There was a great initiative at University of British Columbia Medical School during COVID where they paired them with isolated adults. So everybody was assigned a few people, and you take care of them. You make sure that they get their vaccines, you make sure they get their appointments, and we have to do that stuff routinely, not just in a once-in-a-lifetime pandemic.
I'd like to thank the panelists for their informative presentations. I have a question, and hopefully this can be addressed in terms of, do you have statistics that differentiate between for-profit and not-for-profit long-term care facilities in terms of wellness and or morbidity and ultimately mortality? And are the rules that govern both for-profit and not-for-profit long-term care facilities, and perhaps even retirement residences, the same?
I can tackle that one. So we don't have a lot of good research pre-COVID. We know during COVID that the death rate was higher in for-profit homes, but we have to be careful. So I get this question every single time I do a public event. If we got rid of for-profit care tomorrow, would things be better? No. It's a simplistic solution to a complex problem. So we have to look, why did more people die in for-profit homes? Because they tend to be older, because they have more ward beds, so 4 to a room. So there's all kinds of reasons. The highest death rate in Canada was in Quebec. It has virtually no for-profit care. Almost all the homes are government-owned. So I'd just be cautious that we go down that road. The reality is we do have for-profit care, especially in Ontario. It's about 50-50, and we have to figure out how to regulate it so that it's safe. All homes should be safe. There's really good for-profit homes. There are really good not-for-profit homes. There's really good municipal homes. They'd actually had the best death rates by far, and I think it's because of their connection to the communities. So there's a multiplicity of factors there. The other thing to remember is it doesn't matter if a home's for-profit or not-for-profit, they get the exact same amount of money from the government, approximately $180 a day in Ontario to meet all the needs of a person in a home. So the for-profit part, the extra that you pay is for all kinds of other things like fancy chandeliers, nicer bedding, better meals. It's not, the care portion is still covered publicly, and it's badly covered. So a complex issue that I've touched on very superficially, but just be careful when you hear people say, if we get rid of for-profit homes, everything will be better. It won't. We don't need for-profit homes, in my view, but the reality is they exist, so let's figure out how to make all care homes better, and we can work on the ownership is about number 10 on my list of things to fix. We can get to that later.
Is there a hand over here? Yeah.
Thank you very much for really inspiring talks that you have given. As you said, these lessons are not new. They have been studied many times. And my concern is that all this debate and discussion will remain academic unless the policy makers are here in the room. I don't see any politicians, any local politicians here. I think it's important that we talk to them and put some pressure on them. It's all right for us to learn, but really, in the end, it'll just keep on grinding the same old way that we got used to. So I'm just wondering if you have had any input into our policymakers.
Who wants to tackle that?
Yeah, I mean, I think obviously there's dynamic discussions happening around policy every day, but, you know, I would say, you know, we're sitting in the McMaster Nexus right now. There's a similar Dalai Lama Institute for Pandemics. You know, there is at least an academic bridge and funding that has been created to really study what happened and apply lessons to put policy papers in place. We had a SARS report, though, that said long-term care was a liability, right? And it didn't, as you said, it didn't get regarded in that concept, right? So absolutely, I think pandemic planning has at least been scarred into our communities now to say that this is now a competency in the medical system and policy systems and others to really deal with things. But, you know, as you said, you know, sometimes policy is easy to develop, but hard to enforce by a government that's often here for 4 years and not necessarily concerned about long-term structure and planning, right? And it's not a sexy policy to have in terms of pandemic planning.
I'll just add, you know, not to be too cynical, but governments will do whatever they think the public will tolerate, and the public has tolerated little crappy care. And why? Because we don't want to think about this stuff. No one wants to think I'm going to end up there. That's always going to be my neighbor. It's never going to be me. You know, we just had an election in this province. How many people went into the ballot box and said, I'm sickened by the fact that, about 9,000 of my fellow citizens died in appalling conditions in care homes, and I'm going to vote based on that. Almost nobody voted like that. We let them get away with it. So we're, I think, in many ways, the authors of our own misfortune. Until we make these things ballot box issues, you know, elders vote in very large numbers, but they don't vote for elder care, and they don't vote against ageism. They tolerate this stuff, and it's a weird thing. It's a weird dichotomy. But until we change our attitudes and make politicians pay for this, nothing's going to change, sadly.
Any other comments or questions? I'd be interested from the, oh, there's somebody at the back waving.
Thank you. I just, one more comment I guess I would make. During the day today, and I really enjoyed this presentation, but I get the feeling that the messaging is a bit of, when we say prepare for the next one, that we're forgetting that in long-term care and retirement homes and other congregate living, it's nowhere close to being over. So what are we going to do for the rest of this one that's going to make life significantly better for those that are living there that are quickly put back into lockdown and are still experiencing all the things that you've talked about today. So I just want us to be careful. We're talking about the future when we have the present to still deal with.
Yeah, I think that's very true. I think it's far from over. I think we should be very worried about what's going to happen in the fall. The people who are dying now, our death rate's down a lot, but it's still about 50 people a day. They're still all older people. It's not young people dying. Young people are getting sick, but you know, they can get better. But you're right, we have to keep thinking about the present and not just at the same time as building for the future.
Any comments about the seventh wave this fall that's predicted?
Yeah, I mean, it is challenging looking, you know, it's going to be, the pandemic was easily predictable. You know, we saw, you know, waves and then they came, right? And you know, we looked at South Africa when Omicron hit to kind of expect what would come to us. It's getting harder, and you know, we're seeing different population-based immunity. We're seeing different impacts of variants. And so, you know, I think we know respiratory viruses transmit in the fall and winter, and so I don't think we're going to be escaping the fall and winter without any outcome. You know, I would say this is the year where all the viruses are coming back too, and you know, the winter in healthcare is, especially in acute care, is not easy in the context of flu and the other respiratory viruses that are there. And now we have, even with a low level of infections, a number of people that will have to be admitted for COVID on top of that. So, I think we really do need to, even in the best case scenarios, it's going to be tricky in healthcare. And with adding, healthcare workers leaving in droves, with adding the needs for isolation of healthcare staff that test positive for COVID, it's going to be a tough fall and a tough winter. It's probably not going to be as horrific as it was in the past, but by no means is this winter going to be something that we're going to just fly through and be fine. It never was easy in the winter. It's just added complications now.
I think it actually might be as horrific as in the past. The reality is our death rate is double this year what it was last year, but we've just sort of taken this for granted now. We had 15,000 deaths each of the first 2 years. We've already had 13,000 this year. We're on track to have 25, 30,000 deaths this year, so twice as many. So. Well, let's not end on that super depressing.
No, I'm thinking of some comments.
I will say, though, there is a lot of hope. I will say, we are talking, my last slide was about, potential new vaccines and updates to vaccines for more efficacy. We do have treatments, and again, the actual implementation and rollout to make sure that both low and high vulnerability populations are impacted with it. There are ways to mitigate healthcare utilization and death that didn't exist in 2020 and 2021. The planning needs to happen now, though, right? When the surge happens, it's very, very difficult for innovation to occur. But there are tools to make sure that this, even in this wave, even with what happens, that we use tools from 2022 over 2020.
Right. So, on the last note, I still feel like when we speak to politicians as scientists, we get the glazed look. And really, your voice is what matters. So I'd be very interested from each speaker, all those great suggestions. How can this audience, how can older adults, other than voting, make a difference? Start on my far left.
Okay, well, I'll go with voting again. It is really important, but communicate. Send your MPs, your MPPs letters. That matters. They pay attention because not many people do it. Talk to your, make sure if you have loved ones in care homes, make sure they have a patient committee, get on it. Make sure your local politician visits, smells the place, sees the place. All this stuff is really, you have to make it real to them. So anything you can do to make it real, that's what you do.
So I'm going to say in the hospital, we sit and look at patients' feedback and their families. People are sometimes frightened, not frightened, I shouldn't say use it, but they're concerned that they don't give their feedback. We really look at that. So totally agree, be on a committee, whether in long-term care and acute care.
Yeah, I would add to that by saying speaking out, like looking for every possible avenue to speak out. And sometimes it might be you, and sometimes it might be family members or grandchildren, but using every avenue possible to speak out. You might not have fancy technological skills, neither do I, but your grandchildren might. So even Twitter or social media, using avenues that are available and speaking out, whether it is speaking out in terms of talking to researchers or, but sharing your voices, because your voices matter, your insights matter, your experiences matter, and your wisdom matters. So all of that matters, and you will help to improve the system, and you will help us and researchers and everybody around you, including your families, to take better care of you. So whatever you can do to aid and help will make it possible for us and the next generation.
Yeah, I would reemphasize, I would engage with the local healthcare institutions in acute care and chronic care, but also engage with public health. I think we need to, as we said, we need to know about how to engage populations that could not be engaged. It's everyone's individual experience that generates how we engage with people, right? As one of the people who asked a question, who lives alone, who isn't following the news as well, that isn't savvy with technology, how do we reach that person, right? If you're that person that was reached, tell us. Tell people how to reach them. Make those suggestions. Because again, we know the vulnerability in this population right now, and we don't want to go through another wave, knowing exactly what vulnerabilities have been exposed at the surface. We really do need the feedback and use it to inform systems.
Yes.
Zoomer would be a good one to, ask people. Sorry. I was just thinking with Zoomer, it's probably a good television program, right, to get some of this information out and how we can make a difference, we elders, by, as you say, giving the addresses, giving what phone numbers, whatever we could do to make a statement.
Yeah, I 100%. Zoomer, radio, call in. There are magazines. They're always interviewing. They're one of the top lobby groups to politicians in Canada, and they have a strong voice. So I see a lot of people starting. Thank you. I'm going to have a number of thanks, but thank you to you, most importantly, for coming tonight and spending your evening with us. I'd like to thank our speakers today, who are very informative, Zane, Chandrima, and André Picard, and also to thank the MIRA Institute and Dr. Parminder Raina and his team for hosting us this evening in the CLSA study. So thank you very much, and we look forward to some positive changes.